Welcome to the RNSG 1424 Exam 1 Cumulative Lecture. This auditory lecture briefly reiterates the concepts of professionalism, clinical judgment, safety, immunity, thermoregulation, and comfort with the exemplars for each concept. Remember that the required reading and the listed posted PowerPoints in your modules are essential to learning the information and assisting you in studying for the exam. This is just a brief reiteration of each of these concepts. We hope it is helpful.
The concept of professionalism is defined as the assimilation of nursing skills and knowledge integrated with dignity and respect for all human beings, incorporating the assumptions and values of the profession while maintain accountability and self-awareness. We also describe this as professional nursing practice. The American Nurses Association identifies tenet characteristics of all nursing practice, which include: nursing practice is individualized, nurses coordinate care by establishing partnerships, caring is central to the practice of the registered nurse, registered nurses use the nursing process to plan and provide individualized care to their healthcare consumers, and a strong link exists between the professional work environment and the registered nurse's ability to provide quality healthcare and achieve optimal outcomes. That's what we as nurses, registered nurses, our goal is to achieve optimal outcomes. The profession of nursing has its own distinct body of knowledge, education, and specialty standards of practice. The nurses' standards of practice describe basic competencies in delivering nursing care using the nursing process. The nursing process, as described, is our assessment, diagnosis, planning, implementation, and evaluation, which we'll talk about later. The standards of professional performance are described with behavioral competencies, and that includes practices ethically, which is part of professionalism, attains knowledge and competence that reflects current nursing practice, integrates evidence and research findings into practice, communicates effectively in all areas of practice, demonstrates leadership in the professional practice setting and the profession, collaborates with healthcare consumers, families, and others in the conduct of nursing practice, evaluates his or own practice, utilizes appropriate resources to plan and provide nursing services that are safe, effective, and financially responsible, practices in an environmentally safe and healthy manner. If we utilize all of these expectations and behavioral competencies, we are practicing professionalism within our nursing profession. As a response to the 2003 Institute of Medicine report, the Interprofessional Education Collaborative Expert Panel published core competencies for interprofessional collaborative practice, with the goal to prepare all health profession students for deliberately working together with the common goal of building a safer and better patient-centered and community population-oriented U.S. healthcare system. So within this, the definition of interprofessional collaborative practice involves employing multiple health professionals to work together with patients, families, and communities to deliver best practices, thus assuring best patient outcomes. This goal is devised into collaborative practice competency domains, which include 1. Values and ethics for interprofessional practice, 2. Roles and responsibilities for professional collaborative practice, 3. Interprofessional communication practices, and 4. Interprofessional teamwork and team-based practice. Now, the implementation should result in improved collaborative practice between nurses, physicians, and other health professions, but it also promotes safety, quality care, and best practices. The QSIN, which is Quality and Safety Education for Nurses, was funded by a group to develop curricula that prepared future nurses with the knowledge, skills, and attitudes, abbreviated as KSA, required to continuously improve the quality and safety of the healthcare system. So with this, nurses educated under cues and concepts demonstrate the knowledge, skills, and attitudes consonant with competency in patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. This is extremely important for our profession because this is where we start as students. So quality and safety education for nurses is paramount in a student to understand the quality and safety for nursing profession. The concept communication definition is process of interaction between people where symbols are used to create, exchange, and interpret messages about ideas, emotions, and mind states. In our profession of nursing, communication is vital to our profession and the care of our patients. We need to do assessments, we need to communicate health histories, medications, all types of information. We need to communicate with the patient or caregivers, depending on the age of the patient, and get accurate information. Effective communication is essential. Patients can be nervous, they can be apprehensive, they can be in pain. So effective communication is the nurse's responsibility to obtain information that will be vital to the patient's care. The nurse must be aware of their own nonverbal communication as well as the patient. The nurse needs to take into consideration the patient's educational and cultural background and language proficiency. If a patient does not speak the same language as the nurse, an interpreter must be present. If it must needs be that the facility has implemented the AT&T translation on a phone, then that's what we need to do. So parts of effective communication are establishing rapport so that the bond will be created, putting your patient at ease so that they can think clearly and feel calm when communicating with you. Encourage honest communication. This is vital when we start talking about very intimate areas of the assessment. When we talk about sexual activity and history, when we talk about drug use, when we talk about signs and symptoms of abuse. So honest communication is vital. With that honest communication, we need to make eye contact. Some cultures, it depends, will look at you face to face, or they may look at the ground, but the nurse can look at the patient. Listen to patient's response to questions and concerns. So listening actively, not just asking a question and writing it down. If a patient responds to a question and you feel or they state that they have a concern about something, then address it right then and there. Be aware of your own nonverbal communication, meaning the way you stand, the intonation of your voice, the words that you're stating, the look on your face. Be very non-judgmental. Questions phrased in understandable language and terms. So if a patient has a third grade education, you're not going to be using the big medical jargon. And even if they have a college education, you may not necessarily be using medical jargon because that's not something that they're familiar with. Ask questions non-judgmentally. Ask them open-ended. Ask them without intonation of up and down in your voice. Ask them matter-of-factly. And at the end, summarize at the end of the conversation. Review what you have said. Look over your documentation and see if there's any questions that need to be answered or clarified. The concept clinical judgment definition is an interpretation or conclusion about a patient's needs, concerns, or health problems, and or the decision to take action or not, use or modify standard approaches, or improvise new ones as deemed appropriate by the patient's response. So within our clinical judgment concept is our nursing process, the assessment, the diagnosis, the plan, the implementation, and the evaluation. Part of our nursing process in the assessment is to take a health history. Health histories are a series of questions used to provide an overview of the patient's current health status. We nurses are responsible for obtaining that detailed history of the current health problems, past medical history and family history, and a review of the person's functional status. This will result in a total health profile that focuses on health as well as illness. This is very lengthy part of our assessment process, and our communication is vital. In the assessment, once again, we need to ask questions non-judgmentally. And the components of our health history will include our biographical data, which this is the person's name, address, age, gender, marital status, etc., ethnic origin. It's also our chief complaint. So a question like, why have you come to the health center today? Or why were you admitted to the hospital? Hopefully that will give us the reason of their chief complaint. Then we have present health concern or illness. And this is the single most important factor in helping the healthcare team arrive at a diagnosis or determine the patient's current needs. We would continue that through a physical assessment. They may say things like headaches or fever or changes in bowel habits. So that's where we would need to assess further verbally. We need to know their past health history. The detailed summary of the past health history is an important part, because once we determine the general health status, we need to inquire about things like immunizations and the information about allergies to medications, or things about chest x-rays they've had, electrocardiograms, other tests that they've had, and what the results were. So we could ask things about childhood illnesses, psychiatric illnesses, past hospitalizations, past surgeries. Another information is family history. This is very important to the nursing process. It could be diseases that include genetic, communicable, or possibly environmental in origin. And we would want to know about first order of relatives, which is our parents, siblings, spouse, and children. A second order of relatives is grandparents and cousins. And things about cancer, hypertension, diabetes, tuberculosis, alcoholism, etc. This is very important to know because it might be something that the patient is at risk for. Then we would also do a review of systems. That's the overall general health as well as symptoms related to each body symptom. This isn't the physical assessment yet. This is just a review of every system in the body with the patient. Then we also have our patient profile. That's more biographical information. And this information would be past life events related to health. This could be personal experiences during childhood or adolescence that's given a special significance and may be elicited by asking questions like, was there anything that you experienced as a child or adolescent that would be helpful for me to know? Once again, that needs to be an open-ended question. Was there is a yes or no, but if they say yes, then we say, please share that information. Things about genetics would be important. We also want to know about current medications, prescription, over-the-counter, home remedies, complementary and alternative therapies, education and occupation, jobs held in the past, current job right now, educational preparation, financial resources is important, income, their insurance coverage. We'd also want to know information about their environment, like their physical, which is living arrangements, their spiritual, to religious beliefs related to their perception of health and illness, and interpersonal, things like ethnic background, what customs and values are held, family relationships, and friendships. Lifestyle patterns would be things like sleep, exercise, nutrition, recreation, caffeine amount is part of it, smoking, alcohol, and drugs. Drugs could be over-the-counter also, or illegal. Once again, being non-judgmental. Physical or mental disabilities, presence of that disability, because that has an effect on function and health. Self-concept, that has to do with a lot of the mental health, and sexuality, perception of self as a man or woman, quality of sexual relationships, concerns related to sexual or sexual functioning. And remember, when discussing this, be non-judgmental. In your digital textbook, it gives you questions how you can ask that they're open-ended so that there isn't that anxiety on either end. Also, part of our patient profile is risk for abuse. If they've had physical injury in the past, if they're afraid of a partner or a family member or caregiver, or refusal of caregiver to provide necessary equipment or assistance. That would be also considered neglect. Then stress and coping response. How do they handle it? Do they have concerns or problems? Daily hassles, past experiences, coping patterns, coping strategies. That would be important information that we would use as part of our patient profile. And as we continue on our assessment factor in our nursing process, then we go to the physical assessment. When we do our physical assessment, in order that we do is first inspection. Inspection actually started when you did the verbal history. You saw how they sat, you saw their color, you saw how they acted, you saw if they could hear you, their mouth movements, if they smile, how they walked in, how they sat, how they are sitting, the color of their skin. A lot of things have to do with inspection before you even touch the patient. Once you've completed your inspection, then palpation is next. Palpation has to do with touching. It has to do with listening. So that would be your heart sound, your lung sounds. It has to do with feeling pulses, anything to touch a patient. Then we have the percussion as part of physical assessment. That's where we can test the abdomen or test the lung areas. Then we have auscultation. Auscultation is putting on our stethoscope and listening to lung sounds, listening to heart sounds. That would be of the essence in knowing our physical assessment. As we continue in the clinical judgment concept and continuing with our nursing process, we have completed our assessment and now we move on to a diagnosis. So we would have to use official NANDA nursing diagnoses in all of our profession. So let's say we have a patient that is coming in for appendicitis and they end up having appendectomy. You did your full assessment, you saw how everything was. Now what we need to do is come up with our diagnosis, nursing diagnosis. So we could say something like pain. Remember, nursing diagnoses have three parts if it's an actual diagnosis. So this, I would say pain related to disease process as evidenced by patient stating pain is a 9 out of 10, or patient screaming, or patient crying, especially if it's a pediatric patient. You have to use observation for that. Once we come up with our diagnosis, then we have to come up with a plan. What do we want at the end result? So our plan is, we call them goals or outcomes. So a plan for that nursing diagnosis of pain, my goal could be, once again, it has to have three parts: who, what, and when. So our goal could state the patient will have pain of 3 or less by end of shift. So that would be a goal or an outcome. The next step is implementation, or in other words, our interventions. What are we going to do to reach our goal? So first, you can say one of our interventions would be to intervene with non-pharmacological pain measures, use of distraction, massage, or watching TV. Another would be to give pharmacological measures, whether it's a pain medication that was prescribed by the physician. Another could be turn or move or roll over the patient to relieve pressure. It could also be to reevaluate the pain medication after administered. The last step is evaluation within our nursing process. That is evaluating if our goals were met through our interventions. So my evaluation, if it was successful with this patient that had appendicitis, would be pain was a 2 out of 10 on scale by end of shift, or throughout shift, or within 1 hour after giving pain medication. That's how I know that my implementation and my goal was effective.
The concept of safety definition is protection from harm or injury for patients and providers through both system effectiveness and individual performance. We will be discussing timeouts, core measures, and anticipatory guidance exemplars.
Regarding safety, timeouts are initiated by the Joint Commission's National Patient Safety Goals to prevent mistakes in surgery. It is initiated to prevent the occurrence of wrong patient, wrong site surgical procedures. It is utilized prior to surgery and all invasive procedures. The circulating nurse is responsible for ensuring that the verification of the surgical procedure in site takes place and is documented. In some institutions, this is referred to as the timeout, surgical pause, or universal protocol that takes place among the surgical team prior to induction of anesthesia, with a briefing about anticipated problems, potential complications, allergies, and comorbidities. Every member of the surgical team verifies the patient's name, procedure, and surgical site using objective documentation and data before the beginning of the surgery. Research suggests that the use of a surgical safety checklist reduces morbidity and mortality. It is the circulating nurse's responsibility to perform the documentation, but all OR team members must confirm right patient, right procedure, right surgical site.
The Joint Commission, in cooperation with the Centers for Medicare and Medicaid Services, has developed sets of performance measures for hospitals called core measures. The core measures are used to gauge how well a hospital gives care to its patients who are admitted to seek treatment for a specific disease or who need a specific treatment, as compared to evidence-based guidelines and standards of care. Benchmark standards of quality are used to compare the care or treatment that patients receive as compared to the best practice standards. The percentage of the patients who receive the best care or treatment as specified at a given hospital is then calculated and reported so that hospitals can use those results to continue to improve their processes and performance until they consistently meet best practice standards 100% of the time. The core measures that are utilized at this time in the year 2015 are substance abuse, tobacco treatment, perinatal care, venous thromboembolism, hospital outpatient, acute myocardial infarction, stroke, surgical care, inpatient psychiatric, emergency department, children's asthma, and immunizations. You may use the link below, if you choose, to read further information. Anticipatory guidance focuses on psychologically preparing a person for an unfamiliar event or a painful event. Nurses use this technique to teach patients how procedures and surgical experiences will be. When patients know what to expect, anxiety is reduced and coping mechanisms are more effective. For example, before performing a painful procedure, teaching would include information about the pain involved, like the onset, severity, cause, and also methods of relief. With this knowledge, the patient feels less threatened and tolerates the procedure more easily. There is anticipatory socialization. That is where people prepare themselves for roles to which they aspire but do not yet occupy. This process may be used, for example, to prepare expectant parents for the role of parenting, thereby enhancing the potential for the child to experience normal growth and development. The concept of immunity definition is a physiologic process that provides an individual with protection or defense from disease. The exemplars that we will be discussing are systemic lupus, erythematosus, rheumatoid arthritis, multiple sclerosis, cellulitis, pneumonia, trauma, sprain, and osteomyelitis. Systemic lupus erythematosus is an inflammatory autoimmune disorder that affects nearly every organ in the body. It starts with the body's immune system inaccurately recognizing one or more components of the cell's nucleus as foreign, seeing it as an antigen. The immune system starts to develop antibodies to the nuclear antigen. The antibodies and antigens form antigen. antibody complexes and have the propensity to get trapped in the capillaries of visceral structures. The antibodies also act to destroy host cells. It is thought that those two mechanisms are responsible for the majority of the clinical manifestations of the disease. Given the overwhelming numbers of women with systemic lupus as compared to men, it is hypothesized that female sex hormones also play a role in the predisposition to systemic lupus. It is hypothesized also that an exogenous or environmental trigger is implicated in the onset of the disease process. It has been found also that certain medications have been implicated in chemical or drug-induced systemic lupus, such as hydralazine, procainamide, isoniazid, and thorazine, also some anti-seizure medications. The disease process involves chronic states where symptoms are minimal or absent, and acute flares where symptoms and lab results are elevated. The integumentary, musculoskeletal, renal, nervous system, cardiovascular, and respiratory systems are most commonly involved. The most familiar skin manifestation is an acute cutaneous lesion consisting of a butterfly-shaped erythematous rash across the bridge of the nose and cheeks. For the cardiac system, pericarditis is the most common clinical manifestation. Patients may present with substernal chest pain that's aggravated by movement or inspiration. These symptoms can be acute and severe or last for several weeks at a time. Other cardiac symptoms may include myocarditis, hypertension, dysrhythmias, and valvular incompetence. Nephritis as a result of systemic lupus, also referred to as lupus nephritis, occurs due to a buildup of antibodies and immune complexes that cause damage to the nephrons. Central nervous system involvement is widespread. Psychosis, cognitive impairment, seizures, peripheral and cranial neuropathies, transverse myelitis, and strokes are widely recognized. The focus of systemic lupus treatment is based on pain management and nonspecific immunosuppression. Pharmacologic therapy includes NSAIDs, corticosteroids, antimalarial agents, and cytotoxic agents. But each of these medications has potentially serious side effects, including organ damage. Corticosteroids are a medication that can be used topically for cutaneous manifestations, in low oral doses for minor disease activity, and in high doses for major disease activity. IV administration of corticosteroids is an alternative to traditional high-dose oral administration. One of the most important risk factors associated with the use of corticosteroids in systemic lupus is osteoporosis and fractures. Antimalarial medications are effective for managing cutaneous, musculoskeletal, and mild systemic features of systemic lupus. The NSAIDs are used for minor clinical manifestations and are often used in conjunction with corticosteroids in an effort to minimize corticosteroid requirements. Immunosuppressive agents are used because of their overall effect on the immune function. These medications are generally reserved for patients who have serious forms of systemic lupus and have not responded to conservative therapies. In nursing management, the most common nursing diagnoses include fatigue, impaired skin integrity, body image disturbance, and deficit knowledge for self-management decisions. The patient may benefit from participation in support groups, which can provide disease information, daily management tips, and social support. Because sun and ultraviolet light exposure can increase disease activity or cause an exacerbation, patients should be instructed to avoid exposure or to protect themselves with sunscreen and clothing. Because of the increased risk of involvement of multi-organ systems, patients should understand the need for periodic screenings. A dietary consult may be indicated to ensure that the patient is also knowledgeable about the recommendations, given the increased risk of cardiovascular disease to be included of hypertension and atherosclerosis. The nurse must watch for signs and symptoms of infection, especially with acutely ill patients. due to the immunosuppression associated with systemic corticosteroid usage. Rheumatoid arthritis is an autoimmune disease of unknown origin. The exact mechanism of action for the etiology of rheumatoid arthritis is unknown. However, research has identified that the autoimmune reaction originates in the synovial tissue. It is hypothesized that both environmental factors such as cigarette smoking and genetic factors come together to produce inflammatory and destructive synovial fluid, starting in the more distal joints. The rheumatoid arthritis synovium breaks down collagen, causing edema, proliferation of synovial membrane, and ultimately pannus formation. A pannus is a condition in which a layer of vascular fibrinous tissue extends over the surface of an organ or other specialized anatomical structure. Pannus destroys cartilage and erodes the bone. The consequence is loss of articular surfaces and joint motion. Muscular fibers undergo degenerative changes. Tendon and ligament elasticity and contractile power are lost. In assessing a patient and having diagnostic findings, you will note that the initial clinical manifestations include symmetric joint pain and morning joint stiffness lasting longer than 1 hour. In the early stages, even before the presentation of bony changes, limitation of function can occur when there is active inflammation in the joints. The joints are hot, swollen, and painful, and not easily movable. Immobilization for extended periods can lead to contractures, creating soft tissue deformity. There could be deformities of the hands, like ulnar deviation and swan neck deformity, and feet, which are very common. Rheumatoid arthritis is a systemic disease with multiple extra-articular features. These features, most common, are fever, weight loss, fatigue, anemia, lymph node enlargement, and Raynaud's phenomena, which is cold and stress-induced vasospasm, causing episodes of digital blanching or cyanosis. The history and physical examination focuses on manifestations such as the bilateral and symmetrical stiffness, tenderness, swelling, and temperature changes in the joints. Arthrocentesis shows synovial fluid that is cloudy, milky, or dark yellow and contains numerous inflammatory components such as leukocytes and complement. Regarding rheumatoid arthritis and management, your Hinkle ebook, page 1063, has a chart 39.2, Plan of Nursing Care, Care of Patient with a Rheumatic Disorder. These have the nursing diagnoses, goals, and interventions with rationales and expected outcomes. Pain control is an issue. The goal would be to improve comfort level, incorporation of pain management techniques into daily life. We can provide a variety of comfort measures like heat or cold, massages, position changes, rest, supportive pillow splints, relaxation techniques, of course giving our anti-inflammatories, analgesics, and individualizing medication schedule to meet patients' need for pain management. There are more other interventions utilized in this section, which you can read. Another area would be to incorporate a part of daily activities necessary to modify fatigue. Provide instructions about fatigue. Describe the relationship of the disease activity to fatigue. Provide comfort measures. Develop and encourage a sleep routine. Explain importance of rest. Explain how to use energy conservation techniques, and other interventions are available to read. A third area is to attain and maintain optimal function mobility. Remember, these patients have limited mobility and they must maintain what they do have. I would suggest assessing the need for occupational or physical therapy as a consult and getting them engaged. They can do range of motion. They can provide assistive ambulatory devices. They can explain the use of safe footwear. Identify barriers for environmental barriers like furniture. Encourage independence. Allow ample time for activity. The next area would be to perform self-care activities independently or with the use of resources. Assist the patient to identify self-care deficits and factors, and then develop a plan based on the patient's perceptions. We can provide assistive devices reinforce correct and safe use of these assistive devices, allow patient to control the timing, give them as much control as possible. Another area is adapting to physical and psychologic changes imposed by the rheumatic disease. Help the patient identify the elements to control over. They may have self-concepts that are altered because of the disease and/or the treatments. Encourage the patient to verbalize these feelings, maybe even fears. The individual's coping strategies reflect the strength of their self-concept. The next area is to make sure that we educate our patient regarding self-care and complications secondary to effects of medications. The medications that these patients have multiple side effects and can coincide with each other, and it is of the essence for them to understand how that works. There are many medications utilized to treat rheumatoid arthritis and rheumatic diseases. In Table 39.3 in page 1060 of your Hinkle ebook, there is a table called Medications Used in Rheumatic Diseases. Make sure that you're able to read the action and note nursing considerations and side effects. This teaching must also be done with patients taking these medications. Some medications are salicylates, or in other words, we call it aspirin. Side effects include ringing in ears or tinnitus, gastric intolerance, GI bleeding, and purpura. We also use non-steroidal anti-inflammatory drugs, which we also call NSAIDs. Many different names: diclofenac, NSAID, Motrin, Indocin, all kinds of names. But side effects must be monitored. Monitor for GI, CNS, cardiovascular, renal, hematologic, and dermatologic effects. Avoid the use of aspirin. Use acetaminophen if needed. And watch for possible confusion in older adults. There's another category called disease-modifying anti-rheumatic drugs, or they have it DMARD. Those are the antimalarials and immunosuppressives, gold-containing compounds. Some of the antimalarials, like Plaquenil, side effects include assessing for the visual changes, GI upset, skin rashes, headaches, photosensitivity, and even bleaching of the hair. In immunosuppressives, like methotrexate and Cytoxan, they have an immune suppression that affects DNA synthesis and other cellular effects. You would assess for infection, bone marrow suppression, GI ulcers, skin rashes, bladder toxicity, and alopecia. Corticosteroids are also used in combination with these medications. Corticosteroids are the anti-inflammatory. Be sure to use for the shortest duration possible and at the lowest dose to minimize adverse effects. You can have cataracts, GI irritation, hyperglycemia, hypertension, fractures, avascular necrosis, hirsutism, and psychosis in using this medication. Multiple sclerosis is an immune-mediated, progressive demyelinating disease of the central nervous system. Demyelination refers to the destruction of myelin, which is the fatty and protein material that surrounds certain nerve fibers in the brain and spinal cord. It results in an impaired transmission of nerve impulses. Multiple sclerosis may occur at any age, but the age of peak onset is 25 and 35 years and affects women more frequently than men. A person's immune system is attacked, which leads to inflammation that destroys myelin. Plaques appear on demyelinated axons, further interrupting the transmission of impulses. Demyelinated axons are scattered throughout the central nervous system. The areas most frequently affected are the optic nerves, chiasm, and tracts, the cerebrum, the brainstem and cerebellum, and the spinal cord. The axons themselves begin to degenerate, resulting in permanent and irreversible damage. Signs and symptoms of multiple sclerosis are varied and multiple, reflecting the location of the plaque, or we call it lesion, or combination of lesions. Fatigue affects most people and is often the most disabling symptoms. To assist, avoid hot temperatures, utilize effective treatment of depression and anemia, and occupational and physical therapies may help control this fatigue. Pain is another symptom of multiple sclerosis. It can also contribute to social isolation. Lesions on the sensory pathways cause that pain. Many people with multiple sclerosis need daily analgesic medications. Spasticity, or muscle hypertonicity, occurs in multiple sclerosis patients up to 90%, most often in the lower extremities, and can also include the loss of abdominal reflexes. Cognitive and psychosocial problems may reflect some degree of cognitive change, like memory loss, decreased concentration, occurs in about half of the patients. Involvement of the cerebellum or basal ganglia can produce ataxia, which is that impaired coordination of movements, and tremor. The loss of control connections between the cortex and the basal ganglia can occur and cause emotional lability and euphoria. Bladder, bowel, and sexual dysfunctions are also common. Secondary complications of multiple sclerosis can be urinary tract infections, constipation, pressure ulcers, contracture deformities, dependent pedal edema, pneumonia, and osteoporosis. In considering the older patient with multiple sclerosis, they are particularly concerned about increasing disability, being a family burden, having marital concern, and the possible future need for nursing home care. Visual disturbances are also a manifestation. They can have blurred, diplopia, which is double vision, patchy blindness, or even total blindness. There is no cure for multiple sclerosis. The goals of treatment are to delay the progression of the disease, manage chronic symptoms, and treat acute exacerbations. Symptom management is the treatment. Utilized are medications that can be used for specific symptoms. Baclofen is a medication of choice for treating spasticity. Treatment for fatigue that interferes with activity of daily living may be treated with amantadine and pemilin. Medications that are used to treat ataxia can be beta-adrenergic blockers such as propranolol, anti-seizure medications like gabapentin, and at times benzodiazepines like Klonopin. Bladder and bowel problems are often among the most difficult ones for patients, and medications such as anticholinergic agents and alpha-adrenergic blockers and antispasmodics may be prescribed. Non-pharmacologic strategies can also be utilized in effective bladder and bowel elimination. Urinary tract infections are often superimposed and can be treated with ascorbic acid, or in other words, vitamin C. The major goals for the patient include promotion of physical mobility, avoidance of injury, achievement of bladder and bowel continence, promotion of speech and swallowing mechanisms, improvement of cognitive function, development of coping strengths, improved home maintenance management. Promoting physical mobility includes exercising, minimizing spasticity and contractures, utilizing daily exercises for muscle stretching to minimize joint contractures, activity and rest, where the patient is encouraged to work and exercise to a point just short of fatigue. Nutrition is important. Interventions like promoting healthy eating and weight reductions need to take into account that fatigue and mobility impairments are barriers to the engagement in nutritional behaviors. So nurses need to be certain to include family members in interventions and education. Minimizing effects of immobility, so that complications that are associated with immobility, like pressure ulcers, expiratory muscle weakness, and accumulation of bronchial secretions, should be considered and steps taken to prevent them. Preventing injury is of the utmost importance. If motor dysfunction causes problems of incoordination and clumsiness, or if ataxia is apparent, then the patient is a risk for fall. The patient should be instructed to walk with feet apart to widen the base of the support and increase walking stability. Enhancing bladder and bowel control is important. Bladder symptoms fall into inability to store urine, inability to empty the bladder, or a mixture of both types. In the hospital, a bedpan or a urinal should be readily available. A voiding time schedule is set up about every 1.5 to 2 hours and then lengthening it. The patient is instructed to drink a measured amount of fluid every 2 hours and then attempt to void every 30 minutes after drinking. They can use a timer or a stopwatch. Impaired swallowing increases the risk of aspiration. So enhancing communication and managing swallowing difficulties are of essence. The cranial nerves that control the mechanisms of speech and swallowing are affected. So dysphagia, which is difficulty swallowing, may occur. Strategies from the speech pathologists, where they evaluate speech and swallowing, can help compensate for speech and swallowing problems. These impaired swallowing increase the patient at risk for aspiration. To reduce that risk, the nurse implements strategies such as having the suction apparatus available, ensuring careful feeding, and sitting up properly for eating to help decrease the aspiration risk. Improving cognitive function, such as utilizing the information of vision like an eye patch or a covered eyeglass lens, may be used to block the visual impulses of one eye if the patient has diplopia or double vision. Strengthening coping mechanisms, because multiple sclerosis is always distressing to the patient and family. They need to know that no two patients have identical symptoms or course of illness. Some patients do experience significant disability early, while others have a near normal lifespan with minimal disability. They need to improve home management, promoting home and community-based care, education to the patients about self-care, continuing care after discharge. The nurse can provide education and reinforcement of new interventions in the patient's home. In Chart 69-4, Home Care Checklist, is great information for you to be studying. It tells of the home care education the patient and caregiver must be able to do. They are able to discuss the clinical course of multiple sclerosis, identify coping strategies, identify ways to minimize fatigue, how to prevent injury, discuss ways to manage bladder and bowel function, identify ways to minimize immobility and spasticity, and describe medication regimen and potential adverse effects.
Cellulitis pathophysiology is an acute streptococcal or staphylococcal infection of the skin and subcutaneous tissue. It is usually caused by Staphylococcus aureus. Now, cellulitis can occur at any age and can involve any skin area on the body. It can occur as an extension of a skin wound, as an ulcer, or from furnicles or carbuncles. Cellulitis can be associated with other diseases, including chronic venous insufficiency or stasis dermatitis. Clinical manifestations of cellulitis in a localized reaction will be erythema, pain, edema, and warmth at the site of the skin disruption. Treatment includes mild cases, usually with cephalexin or amoxicillin clavulanic acid, and in more severe cases, and if it's periorbital or orbital cellulitis, it will require IV cephalosporins. Important factors of cellulitis are educating our parents and our patients if they're adults. We want to educate them in being clean, taking showers, drying appropriately, keeping fingernails short, especially in children, so that if they scratch, even if they scratch because of eczema, that it's not traumatizing the tissue and disrupting and giving a portal of entry for microorganisms. If the skin does disrupt, keeping that area very well cleaned, keeping it dry, and if there is a big skin disruption, that they need to go see a physician to see if they need to have antibiotics, whether it be topical or oral. Pneumonia is an inflammation of the lung parenchyma caused by microorganisms, including bacteria, mycobacteria, fungi, and viruses. There's also classifications of pneumonia. There's community-acquired pneumonia, which is pneumonia occurring in the community or less than 48 hours of hospital admission in patients who do not meet the criteria for healthcare-associated pneumonia. Healthcare-associated pneumonia is pneumonia occurring in a non-hospitalized patient with extensive healthcare contact with one or more of the following: hospitalization for greater than 2 days in an acute care facility, residence in a nursing home or long-term care, antibiotic therapy, chemotherapy, or wound care within 30 days, hemodialysis treatment at a hospital or clinic, home infusion therapy or home wound care, and family member with infection due to multi-drug resistant bacteria. The third classification is hospital-acquired pneumonia, which is pneumonia occurring greater than 48 hours after hospital admission that did not appear to be incubating at the time of admission. And the fourth is ventilator-assisted pneumonia, a type of hospital-acquired pneumonia that developed greater than 48 hours after endotracheal tube intubation. With bacterial pneumonia, clinical manifestations are abrupt onset of fever, shaking or chills, a cough causing chest pain, purulent sputum, pleuritic type chest pain. When you do a physical assessment, you can hear consolidation of the lungs, and that is usually also manifested within a chest x-ray. Dullness to percussion over affected area with fremitus, because there's something solid so it sounds dull. Bronchophony, which is abnormal voice sounds heard over the lung with the voice too clear and high-pitched, indicating solidification. Egophony, which is increased resonance of voice sounds with a high-pitched bleeding quality heard especially over lung tissue compressed by pleural effusion. Bronchial breath sounds and crackles. Viral pneumonias are the most common causes of atypical pneumonia because of a viral infection. It has a gradual insidious onset. Patients can manifest with headaches, sore throats, muscle soreness, fatigue, dry cough, mucus sputum. They don't always have experiencing fever and chills. On physical assessment, you can hear scattered wheezes, crackles, and there may be little or no evidence of consolidation. In a chest x-ray, they may have minimal to substantial bilateral infiltrates. When we do labs, if we look at their white blood cells, they will be depressed slightly, less than 10,000. With pneumonia, we as nurses are going to utilize collaborative care. If it's a viral pneumonia, we do supportive care. We're going to give oxygen if needed, and if so, use a pulse oximetry to monitor. We're going to give hydration, PO, and IV. We're going to use aerosol therapy so that if the bronchioles need to be dilated, we can give medications. We can also use humidification with the oxygen if we need to. We can give antipyretics, antitussives, and antihistamines. We can also give nasal decongestants. Now, one thing that we need to be aware of is our geriatric patients. That supportive treatment also includes hydration, but we need to use with caution and with frequent assessment because they have a risk of fluid overload. In bacterial pneumonia, we're going to give oxygen once again if needed and monitor with pulse oximetry. But then we're also going to give antibiotics, and there's many different types of antibiotics that can be utilized. You have a chart actually in your digital textbook. We're going to give hydration therapy once again, aerosol therapy, and antipyretics. If needed, we can do chest physiotherapy and postural drainage to help facilitate the release and the expectorant of the mucus. Preventative measures is we're going to administer a pneumococcal vaccine and educate the patient to have a pneumococcal vaccine when initiated. Those who are at risk and need the pneumococcal vaccine are chronic illness patients, such as those who have heart and lung disease, those who have diabetes, those recovering from severe illness, 65 years of age or older, and those people who are in long-term care facilities. A sprain is an injury to the ligaments and tendons that surround a joint. It is caused by a twisting motion or hyperextension of a joint. Now, the function of the ligament is to stabilize the joint while permitting mobility. So if there's a torn ligament causing a joint to be unstable, blood vessels rupture and edema occurs, the joint is tender, and movement of the joint becomes painful. Now, clinical indicators of sprains are related to the inflammatory response of tissue to injury. So like I shared, blood vessels leak fluid into the tissue. White blood cells will migrate to the area to try to fix, and blood flow increases to the site to try to heal. The inflammatory response results in the edema, the warmth and redness, increased nerve sensitivity and pain, and decreased mobility of the joint. Sprains are graded in the same grading system used for strains. There's a first-degree sprain, which is caused by the stretching of ligamentous fibers, and that results in minimal damage. That's that edema, tenderness, and pain when the joint is moved. A second-degree sprain involves partial tearing of the ligament. That results once again in edema, tenderness, pain with motion, joint instability, and partial loss of normal joint function. The third-degree sprain occurs when the ligament is completely torn or ruptured. That third-degree sprain may also cause evolution of the bone. Those symptoms are pain, tenderness, increased edema, and abnormal joint motion. Treatment for sprains depends on the degree of the ligament damage. If it's a first-degree sprain, we use the acronym RICE. R means to rest, I means to ice, C means to compress, and E means to elevate. The resting prevents additional injury and promotes healing. The ice helps to decrease that swelling and bleeding and edema and discomfort. The compression helps to decrease discomfort and controls bleeding and reduces edema and gives support to those injured tissues. The elevation at or above the level of heart controls the swelling. If it's a second-degree sprain, we would do immobilization with splinting or bracing. If it's a third-degree sprain, we have longer immobilization and possibly arthroscopic surgery. After the acute inflammatory stage, which is about 24 to 72 hours after the injury, heat may be applied intermittently to relieve muscle spasm, promote vasodilatation, absorption, and repair.
Osteomyelitis is an infection of the bone that results in inflammation and necrosis and formation of new bone. More than 50% of bone infections are caused by Staphylococcus aureus, and an increasingly of that variety is methicillin resistant. Other pathogens include the gram-positive organisms of streptococci and enterococci, followed by gram-negative bacteria, including Pseudomonas. The initial response to infection is inflammation, increased vascularity, and edema. After 2 or 3 days, thrombosis of the local blood vessels occur, resulting in ischemia with bone necrosis. The infection extends into the medullary cavity and under the periosteum and may spread into adjacent soft tissues and joints. Unless the infective process is treated promptly, a bone abscess forms. The resulting abscess cavity contains dead bone tissue, which is called the sequestrum, which does not easily liquefy and drain. Therefore, the cavity cannot collapse and heal, as it does not in soft tissue abscesses. Therefore, new bone growth forms and surrounds the sequestrum. Although healing appears to take place, a chronically infected sequestrum remains and produces recurring abscesses throughout the patient's life. This is referred to as chronic osteomyelitis. Patients who are high risk for osteomyelitis include older adults, those who are poorly nourished or obese, those with impaired immune systems, those with chronic illnesses such as diabetes or rheumatoid arthritis, those receiving long-term corticosteroid therapy or immunosuppressive agents, and IV drug users. Post-operative surgical wound infections typically occur within 30 days after surgery. Clinical manifestations when the infection is bloodborne is the onset is usually sudden, occurring often with the clinical and laboratory manifestations of sepsis, like chills, high fever, rapid pulse, and general malaise. When the infected area becomes painful, swollen, and extremely tender, the patient may describe a constant pulsating pain that intensifies with movement as a result of the pressure of the collecting purulent material, the pus. When osteomyelitis occurs from spread of adjacent infection or from direct contamination, there are no manifestations of sepsis. The area is swollen, warm, painful, and tender to touch. In acute osteomyelitis, early X-ray findings demonstrate soft tissue edema. An MRI can be performed that will help with early definitive diagnosis. Blood studies reveal leukocytosis and an elevated erythrocyte sedimentation rate. Wound and blood culture studies are performed, although they are only positive in 50% of the cases. With chronic osteomyelitis, the ESR, erythrosedimentation rate, and the WBC count are usually normal. Anemia associated with chronic infection may be evident. Cultures of the blood specimens and drainage from the sinus tract are frequently unreliable for isolating the organism involved. Antibiotic therapy is many times prescribed presumptively. For management, we utilize antibiotics for 3 to 6 weeks. After the infection appears to be controlled, the antibiotic may be administered orally. We also can utilize surgical management. If the infection is chronic, it does not respond to antibiotic therapy, surgical debridement is indicated. The infected bone is surgically exposed, the purulent and necrotic material is removed, and the area is irrigated with sterile saline solution. Prevention of osteomyelitis is the goal. Elective orthopedic surgery should be postponed if the patient has a current infection, like urinary tract infections or even a sore throat. During surgeries, careful attention should be paid to the surgical environment. Prophylactic antibiotics can be administered to achieve adequate tissue levels at the time of surgery and for 24 hours after surgery. Urinary catheters and drains are removed as soon as possible to decrease the incidence of the spread of infection. Aseptic technique postoperative wound care reduces the incidence of superficial infections and osteomyelitis. With our nursing interventions and our nursing care, we must relieve pain. The affected part may be immobilized with a splint to decrease pain and muscle spasm. Wounds are frequently painful and the extremity must be handled with care and gentleness. Elevation reduces swelling and associated discomfort. And of course, pain is controlled with prescribed analgesic agents and other pain-reducing techniques. We must also improve physical mobility, but treatment regimens restrict weight-bearing activity. The bone is weakened by the infective process and must be protected by avoidance of stress on the bone. The patient must understand the rationale for the activity restrictions. Controlling the infectious process, the nurse must monitor the patient's response to antibiotic therapy. Intensive antibiotic therapy, the patient may have a superinfection, which is an oral or vaginal candidus, loose or foul-smelling stools. The nurse carefully monitors the patient for the development of additional sites that are painful or sudden increase in body temperature. If the nurse sees this, she must request and can ask for an X-ray or an MRI of the site and to be assessed by the physician. If surgery is necessary, the nurse takes measures to ensure adequate circulation to the affected area, to maintain needed immobility, and to ensure the patient addresses to the adherence of the weight-bearing restrictions. Promoting home and community-based care is essential. We must educate patients about self-care. The patient and family are educated about the importance of strictly adhering to the therapeutic regimen of antibiotics. Patients and families often need to learn to maintain and manage IV access and IV administration equipment in the home and medications names, dose, frequencies, rates, safe storage, and handling. Look at Chart 42-7 Home Care Checklist for osteomyelitis. The patient and/or family caregiver must describe osteomyelitis, relieve pain, state weight-bearing and activity restrictions, demonstrate safe use of ambulatory aids and assistive devices, describe the use of prescribed medications, promote healing through aseptic dressing changes, demonstrate proper wound care, and report signs and symptoms of continued infection or superinfection. If a patient has diabetes, to help prevent osteomyelitis, they should learn about meticulous foot care. The concept of thermoregulation definition is the process of maintaining core body temperature within an optimal physiological range. We will be discussing fever and malignant hyperthermia as exemplars.
There are different types of fevers regarding thermoregulation. The types of fevers are intermittent, remittent, relapsing, constant, and a fever spike. The etiology of fevers are many factors. There's a response to infection, a response to tissue breakdown, dehydration, and brain injury or brain trauma. Now, common sites of postoperative infection include lungs, urinary tract, incisions, and intravascular catheters. Meticulous care is used to prevent contamination at the sites of the catheter and tube insertions. Aseptic technique is used when changing dressings and providing endotracheal tube and catheter care. Now, something called post-pericardiotomy syndrome may occur in patients who undergo cardiac surgery. The syndrome is characterized by fever, pericardial pain, pleural pain, dyspnea, and pericardial effusion, and arthralgia. Now the issue is these signs and symptoms may occur, and they can occur days to weeks after surgery. So the nurse must be alert to fevers, but also other signs and symptoms to know which disease process to evaluate. Interventions for fever include remove all bedding over a patient. Many times I've actually gone into pediatric rooms and found the baby wrapped up in 2 or 3 blankets and it's already warm in the room. So when I take the axillary temp, the patient seems to be having a fever. But if we remove all those bedding and blankets over the patient, the temperature goes down. Also, interventions are giving antipyretic medications. We can use cool sponge baths, but not too cool because then we don't want them to become hypothermic. We can use hypothermia blankets, and obviously we need to frequently temperature monitor the patient. Malignant hyperthermia is a rare life-threatening condition triggered by exposure to most anesthetic agents, including a drastic and uncontrolled increase in skeletal muscle oxidative metabolism that can overwhelm the body's capacity to supply oxygen, remove carbon dioxide, and regulate body temperature, eventually leading to circulatory collapse and death if untreated. It is often inherited as an autosomal dominant disorder. Clinical manifestations are related to cardiovascular and musculoskeletal activity. Tachycardia, heart rate greater than 150, is often the earliest sign. Sympathetic nervous stimulation also leads to ventricular dysrhythmias, hypotension, decreased cardiac output, oliguria. Later, it can have cardiac arrest. The rise in temperature is actually a late sign that develops rapidly. Body temperature can increase 1 to 2 degrees Celsius every 5 minutes, and core body temperature can exceed 42 degrees Celsius, which is 107 degrees Fahrenheit. When detecting cardiovascular problems, look at the oxygen saturations. They're going to decrease. Look at the heart rate. It will get tachycardic. And their muscles become rigid because it also involves the musculoskeletal activity.
The concept comfort definition is a state of physical ease. The exemplars we will be discussing are phantom limb pain, diabetic neuropathy, pancreatitis pain, sickle cell pain, chronic, and renal calculi. Phantom limb pain occurs after an amputation of a limb. Complications that may occur with amputation include hemorrhage, infection, skin breakdown, phantom limb pain, and joint contracture. The phantom limb pain, which is pain perceived in the amputated section, is caused by the severing of those peripheral nerves after the amputation. In managing this patient, we must consider interventions that were reviewed in Chart 43.8 Home Care Checklist Amputation. What the nurse does is relieve pain. They can utilize opioids per order. The pain is described as if the amputated limb feels crushed, cramped, or twisted in an abnormal position. This pain is sometimes accompanied by numbness or tingling. Phantom pain occurs intermittently and unpredictably. Episodes of pain may last seconds or hours. When a patient describes phantom pains or sensations, the nurse acknowledges these feelings as real and encourages the patient to verbalize when in pain so that effective treatment may be given. Phantom pain typically diminishes over time for most patients, with episodes gradually becoming less frequent and lesser duration. The opioid analgesics may be effective in relieving pain. In addition, beta blockers may relieve dull, burning discomfort. Anti-seizure medications control stabbing and cramping pain. Tricyclic and antidepressants may not only alleviate phantom pain, but may also be prescribed to improve mood and coping abilities. In promoting wound healing, the residual limb must be handled very gently. Whenever the dressing is changed, aseptic technique is required to prevent wound infection and possible osteomyelitis. If a cast or elastic dressing inadvertently comes off, the nurse must immediately wrap the residual limb with an elastic compression bandage. If this is not done, excessive edema will develop over a short time, resulting in delay in rehabilitation. Enhancing body image is of essence. The nurse encourages the patient to look at, feel, and care for the residual limb. It is important to identify the patient's strengths and resources to facilitate rehabilitation. The nurse helps the patient regain the previous level of independent functioning. The patient who is accepted as a whole person is more readily able to resume responsibility for self-care, self-concept improves, and body image changes are accepted. Even with highly motivated patients, this process may take months. Diabetic neuropathy refers to a group of diseases that affect all types of nerves, including peripheral, which is sensory-motor, autonomic, and spinal nerves. The disorders appear to be clinically diverse and depend on the location of the affected nerve cells. The etiology of neuropathy may involve elevated blood glucose levels over a period of years. The pathogenesis of neuropathy may be attributed to either a vascular or metabolic mechanism or both. Capillary basement membrane thickening and capillary closure may be present. In addition, there may be demyelinization of the nerves, which is thought to be related to hyperglycemia. The two most common types of diabetic neuropathy are sensory-motor polyneuropathy and autonomic neuropathy. Sensory-motor polyneuropathy is also called peripheral neuropathy. With peripheral neuropathy, it most commonly affects the distal portions of the nerves, especially the nerves of the lower extremities. It affects both sides of the body symmetrically and may spread in a proximal direction. The clinical manifestations include initial symptoms, which are paresthesias, which is like prickling, tingling, or heightened sensation, and burning sensations, especially at night. As the neuropathy progresses, the feet become numb. A decreased sensation of light touch may lead to an unsteady gait. Decreased sensations of pain and temperature place patients with neuropathy at risk for injury and undetected foot infections. To manage this, intensive insulin therapy and control of blood glucose levels delay the onset and slow the progression of neuropathy. Various approaches to pain management can be tried. These include analgesic agents, preferably non-opioid, tricyclic antidepressants and other antidepressant medications, anti-seizure medications, things like gabapentin or mexiletine, and transcutaneous electrical nerve stimulation. With autonomic neuropathies, it is the neuropathy of the autonomic nervous system resulting in a broad range of dysfunctions affecting most every organ system of the body. These clinical manifestations have three. The three manifestations of autonomic neuropathy are related to the cardiac, gastrointestinal, and renal systems. Cardiovascular symptoms range from a fixed, slightly tachycardic heart rate and orthostatic hypotension to silent or painless myocardial ischemia and infarction. Delayed gastric emptying may occur with the typical gastrointestinal symptoms of early satiety, bloating, nausea, and vomiting. Diabetic constipation or diarrhea may occur as a result. In addition, there may be unexplained wide swings in blood glucose levels related to inconsistent absorption of the glucose from ingested foods secondary to the inconsistent gastric emptying. For the management, strategies for autonomic neuropathy focus on alleviating symptoms and on modification and management of risk factors. Detection of painless cardiac ischemia is also important, so that education about avoiding strenuous exercise can be provided. Orthostatic hypotension may respond to a diet high in sodium. Discontinuation of medications that impede autonomic nervous system responses. The use of simple mimetic and other agents like caffeine that stimulate an autonomic response. Mineral corticoid therapy and the use of lower body elastic garments that maximize venous return and prevent pooling of blood in the extremities. Treatment of delayed gastric emptying continues and includes a low-fat diet, frequent small meals, frequent blood glucose monitoring, and the use of agents that increase gastric motility. Treatment of diabetic diarrhea may include bulk-forming laxatives or antidiarrheals. Constipation is treated with a high-fiber diet and adequate hydration. Medications, laxatives, and enemas may be necessary if constipation is severe. Pancreatitis, which is inflammation of the pancreas, is a serious disorder. Although the mechanisms causing pancreatic inflammation are unknown, pancreatitis is commonly described as autodigestion of the pancreas. Self-digestion of the pancreas by its own proteolytic enzymes, principally trypsin, causes acute pancreatitis. 80% of patients with acute pancreatitis have biliary tract disease, such as gallstones, or a history of long-term alcohol abuse. These patients usually have had undiagnosed chronic pancreatitis before their first episode of acute pancreatitis. Other less common causes of pancreatitis include bacterial or viral infections, with pancreatitis occasionally developing as a complication of mumps viral infection. In the assessment and diagnostic findings, the diagnosis of acute pancreatitis is based on history of abdominal pain, the presence of known risk factors, physical examination findings, and diagnostic findings. The serum amylase and lipase levels are used in making the diagnosis of acute pancreatitis. Serum amylase and lipase levels are elevated within 24 hours of the onset of the symptoms. Serum amylase usually returns to normal within 48 to 72 hours, but the serum lipase levels may remain elevated for a longer period, often days longer than amylase. The white blood cell count is usually elevated also. The management of acute pancreatitis is directed toward relieving symptoms and preventing or treating complications. All oral intake is withheld to inhibit stimulation of the pancreas and its secretion of enzymes. Parenteral nutrition plays an important role in the nutritional support of patients with severe acute pancreatitis. Ongoing research has shown positive outcomes with the use of enteral feedings. The current recommendation is whenever possible, the enteral route should be used to meet nutritional needs in patients with pancreatitis. This strategy also has been found to prevent infections, complications safely, and cost-effectively. Nasogastric suction may be used to relieve nausea and vomiting and to decrease painful abdominal distension and paralytic ileus. Histamine 2 antagonists such as cimetidine and ranitidine may be prescribed to decrease pancreatic activity by inhibiting secretion of gastric acid. Proton pump inhibitors such as protonics may be used for patients who do not tolerate the H2 antagonists. For pain management, adequate administration of analgesia is essential during the course of acute pancreatitis to provide sufficient pain relief and to minimize restlessness, which may stimulate pancreatic secretion further. Pain relief may require parenteral opioids such as morphine, fentanyl, or hydromorphone. There was no clinical evidence to support the use of meperidine for pain relief in pancreatitis. Antiemetic agents may be prescribed to prevent vomiting. In sickle cell disease, the sickle cell anemia is a severe hemolytic anemia that results from inheritance of the sickle hemoglobin HbS gene, which causes the hemoglobin molecule to be defective. The oxygen level in venous blood can be low enough to cause this change. Consequently, the erythrocyte containing HbS loses its round, pliable, biconcave dish shape and becomes dehydrated, rigid, and sickle-shaped. These long, rigid erythrocytes can adhere to the endothelium of small vessels. When they adhere to each other, blood flow to a region or an organ may be reduced. If ischemia or infarction results, the patient may have pain, swelling, and fever. Precipitating factors are cold temperatures, dehydration, low oxygen, infection, and stress. Cold can aggravate the sickling process because vasoconstriction slows the blood flow. Oxygen delivery can also be impaired by an increased blood viscosity, with or without occlusion, due to adhesion of sickled cells. Patients with sickle cell are unusually susceptible to infection, particularly pneumonia and osteomyelitis. Complications of sickle cell anemia include infection, stroke, renal failure, impotence, heart failure, and pulmonary hypertension. There are 3 types of sickle cell crises in the adult population. The most common is the very painful acute vaso-occlusive crisis, which results from entrapment of erythrocytes and leukocytes in the microcirculation, causing tissue hypoxia, inflammation, and necrosis due to inadequate blood flow to a specific region of tissue or organ. Aplastic crisis results from infection with the human parvovirus. The hemoglobin level falls rapidly and the marrow cannot compensate, as evidenced by an absence of reticulocytes. Sequestrian crisis results when other organs pool the sickled cells. Although the spleen is the most common organ responsible for sequestration in children, most children with sickle cell anemia have had a splenic infarction by 10 years of age, and the spleen is then no longer functional. In adults, the common organs involved in sequestration are the liver and, more seriously, the lungs. In the care of the patient with the sickle cell disease, during the crisis, interventions is included supportive therapy. Pain is a significant issue. The incidence of painful sickle cell crises is highly variable. Many patients have pain on a daily basis. The use of medication to relieve acute pain is important. Aspirin is very useful in diminishing mild to moderate pain. It also diminishes inflammation and potential thrombosis. Non-steroidal anti-inflammatory drugs are useful for moderate pain or in combination with opioid analgesics. When opioid analgesics are used, morphine is the medication of choice for acute pain. Also, in managing pain during a sickle cell crisis, the patient's subjective description of pain and the pain scale must guide the use of the analgesic agent. Any joint that is acutely swollen should be supported and elevated until the swelling diminishes. Relaxation techniques, breathing exercises, and distraction are helpful for some patients. After the acute painful episode has diminished, aggressive measures should be implemented to preserve function. Things such as physical therapy whirlpool baths, and transcutaneous electrical nerve stimulation are examples of such modalities. Assessing and managing dehydration is also essential. Adequate hydration is important during a painful sickling episode. Oral hydration is acceptable if the patient can maintain adequate fluid intake. We can also utilize IV hydration with dextrose and water or dextrose and normal saline. Managing fatigue is of essence. Another significant issue with the fatigue and its cause is multifactorial. Fatigue is due to hypoxia, which in turn is due to low levels of normal hemoglobin and decreased oxygen affinity of sickled hemoglobin. The hemolysis occurring in sickle cell disease and resultant anemia is associated with oxyhemoglobin desaturation due to acute splenic sequestration or to infection. These patients can also develop tissue hypoxia when the hematocrit approaches more normal levels. Because the sickling process can interrupt circulation in any tissue or organ with resultant hypoxia and ischemia, a careful assessment of all body systems is necessary. Particular emphasis is placed on pain, swelling, and fever. Because patients with sickle cell anemia are susceptible to infections, they are assessed for the presence of any infectious process. Nurses' care focuses on monitoring patients of the infection. Prescribing antibiotics are initiated promptly. Patients should continue to be assessed for signs of dehydration. Promoting coping skills is essence. This illness can leave the patient feeling powerless and decrease self-esteem because its acute exacerbations often result in chronic health problems. These feelings can be exacerbated by inadequate management of pain and fatigue, and enhancing management of pain and fatigue can be extremely useful in establishing a therapeutic relationship based on mutual trust. Nursing care that focuses on the patient's strengths rather than deficits can enhance effective coping skills. Urolithiasis and nephrolithiasis refer to stones, calculi, in the urinary tract and kidney. Stones are formed in the urinary tract when urinary concentrations of substances such as calcium oxalate, calcium phosphate, and uric acid increase. Stones may be found anywhere from the kidney to the bladder and may vary in size from minute granular deposits called sand or gravel to bladder stones as large as an orange. Stone formation is not clearly understood, and there are a number of theories about their causes. One theory relates to fluid volume status of the patient. Stones tend to occur more often in dehydrated patients. Certain factors favor the formation of stones, including infection, urinary stasis, and periods of immobility, all of which slow renal drainage and alter calcium metabolism. With clinical manifestations, signs and symptoms of stones in the urinary system depend on the presence of obstruction, infection, and edema. Stones in the renal pelvis may be associated with an intense, deep ache in the costovertebral region. Hematuria is often present. Pyuria may also be noted. If pain suddenly becomes acute with tenderness over the costovertebral area and nausea and vomiting occur, the patient having an episode of renal colic. Diarrhea and abdominal discomfort are due to renal intestinal reflexes and the anatomic proximity of the kidneys to the stomach, pancreas, and large intestine. With assessment and diagnostic findings, the diagnosis is confirmed by x-rays of the kidneys, ureters, and bladder, which we call KUB, or by ultrasonography, IV urography, and retrograde pylography. Blood chemistries and a 24-hour urine test for the measurement of calcium, uric acid, creatinine, sodium, pH, and total volume are part of the diagnostic workup. Dietary and medication histories and family history of renal stones are obtained to identify factors predisposing the patient to the formation of stones. The goal for renal calculi is that the patient have relief of pain and discomfort, prevention of recurrence of renal stones, and absence of complications. The nursing interventions that are utilized is relieving pain. Severe acute pain is often the presenting symptom of a patient with renal and urinary calculi and requires immediate attention. Opioid analgesic agents, IV or intramuscular, may be prescribed and administered to provide rapid relief along with an IV NSAID. The patient is encouraged and assisted to assume a position of comfort. If activity brings pain relief, the patient is assisted to ambulate. Monitoring managing potential complications. We can increase fluid intake and encourage that to prevent dehydration and increase hydrostatic pressure within the urinary tract to promote passage of the stone. If the patient cannot take adequate fluids orally, IV fluids are prescribed. All urine is strained through gauze because uric acid stones may crumble. Any blood clots passed in the urine could be crushed and the sides of the urinal and bedpan inspected for clinging stones. Because renal stones increase the risk of infection, sepsis, and obstruction of the urinary tract, the patient is instructed to report decreased urine volume, bloody or cloudy urine, fever, and pain. Patients with calculi require frequent nursing observation to detect the spontaneous passage of a stone. The patient is instructed to immediately report any sudden increases in pain intensity because of the possibility of a stone fragment obstructing a ureter. Vital signs including temperature are monitored closely to detect early signs of infection. Urinary tract infections may be associated with renal stones due to an obstruction from the stone or from the stone itself. All infections should be treated with the appropriate antibiotic agent before efforts are made to dissolve the stone. We must educate the patient. Because the risk of recurring renal stones is high, the nurse provides education about the cause of kidney stones and recommendations to prevent the recurrence. If you as the student look on chart 5512, Preventing Kidney Stones, it will help establish the knowledge that is needed. If lithotripsy, percutaneous stone removal, ureteroscopy, or other surgical procedures for stone removal have been performed, the nurse instructs the patient about the signs and symptoms of complication, like urinary retention or infection, that need to be reported to the physician.